Thank you for joining. On the behalf of the American Heart Association, I would love to welcome you to the Advancing Maternal Health, Exploring the Impact of Hypertension Guidelines in Pregnancy webinar. I'm Elise, a Senior Program Manager at the American Heart Association and your host for today's webinar. This event was made possible through the American Heart Association's Advancing Maternal Health through quality improvement and professional for Mothers, Merck's global maternal health effort to help create a world where no woman has to die while giving birth. The goal of this initiative is to improve postpartum systems of care related to cardiovascular health and expand professional education and training opportunities. Before we begin, I'd like to quickly review how to use this platform for today's event. If you experience any technical difficulties, most user issues can be resolved by refreshing your browser. If that doesn't work, please review the system requirements or contact the Zoom webinar helpline. To access live closed captioning, please click on the closed caption button found on the bottom of your screen. Throughout today's presentation, you will have the opportunity to submit text questions for presenters using the Q&A feature on your control panel. You may send in your questions at any time, and we will review the questions as time allows. Finally, this webinar will be recorded and available on heart.org/maternal health within the coming weeks. As we get into our discussion today around pregnancy, postpartum, and blood pressure, we'd like to share our why on this work. Pregnancy-related deaths in the US has risen 140% over the last 3 decades, and cardiovascular disease is the leading cause. Heart disease during pregnancy leaves women with a higher lifetime risk for cardiovascular disease after pregnancy and can lead to increased risk for their children. More specifically, high blood pressure during pregnancy, preeclampsia, or diabetes are associated with significantly greater risk for later heart disease and even death. Despite existing guidance on pregnancy and cardiovascular health, current trends in Now, let's get into our discussion to discuss the updated guidance and practical implications of the American Heart Association and ACC 2025 Blood Pressure Guidelines. Today's presenters are Dr. Carolyn Zellup, Dr. Crystal Graves, Dr. Aaron Ferranti, and Dr. Suppley. These experts represent a core part of the Postpartum Care Champion Group, a team that has been dedicated to advancing this initiative since its inception. Please note the recommendations and opinions presented by our guest speakers today may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the American Heart Association, and the American Heart Association does not endorse any product or device. To begin, I am very delighted to introduce Dr. Carolyn Zellup. Dr. Zellup is director of fetal echocardiography and perinatal research at Valley Health System and a clinical professor of OB-GYN at NYU Grossman School of Medicine. With that, I will now turn it over to you, Dr. Zellup.
Good day. Thank you for that great introduction and allowing me to join the conversation. To frame our discussion today, I think it's important to reiterate that cardiovascular disease is the leading etiology behind pregnancy-related deaths, and complications from hypertension play a pivotal role in the pathophysiology. The American Heart has released updated guidelines to serve as an evidence-based framework for the prevention, detection, and the management of hypertension for adults. Our focus today is to underscore the relevance of these guidelines to all facets of the reproductive life cycle. Before I begin, I want to disclose my two conflicts of interest. I receive royalties from UpToDate for authorship related to cardiac arrest and pregnancy, and I have received an honorarium for Grand Rounds presentations on cardiac arrest and pregnancy. So with the introduction of these new guidelines, it's important to realize that the American Heart Society wanted to include special populations, particularly pregnancy. And our goal today is to summarize the key updates on definitions and thresholds for classifying the presence and severity of hypertension in the context of pregnancy, including preconception, postpartum, and interconception phases of care. So let's go and start with, here's what we know. So high blood pressure is the most prevalent and modifiable risk factor for the development of cardiovascular disease, including coronary artery disease, heart failure, atrial fibrillation, stroke, dementia, chronic renal disease, and even all-cause mortality. The overarching theme of these guidelines is that blood pressure treatment has the goal of achieving a blood pressure of less than 130 over 80 millimeters of mercury for all adults, with additional considerations for certain populations, such as pregnancy. So let's start, as we're taking our deep dive into these guidelines, with some definitions and classifications. What comes through loudly and clearly from these guidelines is that all adults should have their blood pressure categorized as normal, elevated, stage 1 or stage 2 hypertension to prevent and treat high blood pressure. So the normal range, as you can see in this table, is a systolic blood pressure of less than 120 millimeters of mercury and a diastolic blood pressure of less than 80 millimeters of mercury. Elevated involves a systolic blood pressure of 120 to 129 millimeters of mercury. And stage 1 has two possibilities: an increase in the systolic blood pressure between 130 and 139 millimeters of mercury, and the diastolic between 80 to 89 millimeters of mercury. And stage 2 hypertension is greater than or equal to 140 millimeters of mercury or greater than or equal to 90 millimeters of mercury. So let's continue and now bring those concepts into discussing hypertension and pregnancy. So we know that hypertension in pregnancy requires special consideration when choosing medications that are going to be used for treatment. Traditionally, in the non-pregnant patient, you see the use of angiotensin converting enzyme inhibitors and angiotensin receptor blockers. These, however, do not have a favorable profile for the safety of the fetus. And so the primary medications that are going to be used to treat hypertension in pregnancy are labetalol and nifedipine. Additionally, pregnant patients at risk for preeclampsia, a disease we'll discuss in detail later in this discussion, should receive 81 milligrams a day of aspirin to reduce the risk of superimposed preeclampsia and its sequelae. Importantly, in pregnant individuals, as in non-pregnant individuals, the treatment guidelines or the goal of the guidelines for treatment are to reduce the blood pressure to less than 140 over 90. And it's been found in recent studies, such as the CHAP study published in 2022 in the New England Journal, that lowering the blood pressure in patients with chronic hypertension to less than 140 over 90 not only prevented maternal and perinatal morbidity and mortality, but it also did not cause any increased harm to the fetus in terms of growth restriction. Regardless of pregnancy or not, severe hypertension can be life-threatening, and the goal is to decrease the systolic blood pressure to greater than or equal to 160 millimeters, or diastolic of greater than 110 millimeters of mercury. This is severe hypertension, and it can be life-threatening. Treatment must be methodical and urgent. The blood pressure needs to be repeated, and within 30 to 60 minutes, medication must be used to decrease the level below these thresholds to allow the brain to autoregulate blood flow and prevent complications such as stroke. So one of the other things that is important to emphasize is that the American Heart Guidelines mirror and validate the classifications used by both American College of OBGYN and Society of Maternal Fetal Medicine, so that there is continuity and consistency among the classification system used by these societies. And this is to enable healthcare professionals to use a common language and choose a common way to approach treatment strategies. So let's discuss a little bit more the classification system of hypertension in pregnancy. Chronic hypertension is defined as a diagnosis prior to pregnancy or at less than 20 weeks gestation. Gestational hypertension is de novo onset of hypertension at greater than or equal to 20 weeks of gestation in the absence of proteinuria or other signs of preeclampsia, which involve other end organs. Preeclampsia is defined as a gestational hypertension with proteinuria or other maternal end organ dysfunction that would be manifested manifested with neurological findings, pulmonary edema, hematological findings, acute kidney injury, and even hepatic dysfunction. One or more of these parameters could be present, and if they are present, the severity of which may lead to not only preeclampsia, but severe preeclampsia to be diagnosed. Preeclampsia superimposed on chronic hypertension occurs when preeclampsia develops in a patient with a history of hypertension that started before pregnancy or before 20 weeks of gestation. And the classification and definitions are important for clinical management. So to reiterate, and these are consistent between the American Heart and the American College of OBGYN, the diagnostic criteria for hypertension in pregnancy is defined as a systolic blood pressure of greater than or equal to 40 millimeters of mercury, or a diastolic blood pressure of greater than or equal to 90 millimeters of mercury. And a severe range is the same in both in pregnancy and outside of pregnancy, with severe hypertension being greater than or equal to 160 millimeters of mercury and/or a diastolic of greater than or equal to 110 millimeters of mercury. Let's continue and discuss further. So what about using treatment and medications? And so we've already talked about the fact that there would be different choices in pregnancy to guard the safety of both the pregnant patient and the fetus. Labetalol is a beta blocker that also allows for decreasing peripheral vascular resistance. It can be used safely in divided doses given twice daily orally. It is to be avoided, particularly in patients that have significant asthma and maybe other myocardial diseases, since labetalol could potentially exacerbate those underlying conditions. Nifedipine is a calcium channel blocker that also works by decreasing peripheral vascular resistance, and the extended release formulation is perfect for use in pregnant patients. It can be given once daily, starting at dosages ranging to 30 to 60, but increased up to 120 milligrams daily, given orally. Of note, the sublingual form should be avoided because this could cause severe hypotension. And the immediate release formulation should be reserved for control for severe hypertension, particularly in hospitalized patients. Other oral hypertensive agents that have been used are less favorable choices. Methyldopa is an oral agent that works by decreasing central sympathetic outflow. Although it does have a great safety record and it's been around for more than 50 years with long-term follow-up in children whose mothers took this medication during pregnancy, the problem with methyldopa is that it takes a while to start working, even days, and it is not effective to be used for the treatment of severe hypertension. And the side effect profile is not very pleasant for patients, so it doesn't enhance adherence to the medication. So there are other choices, the first two that I mentioned, labetalol and nifedipine, that make much more sense in this population. Hydrochlorothiazide is a diuretic, and this medication, while used potentially as a second line or for even first line agent in non-pregnant patients, is generally not used for blood pressure management. It's used in the management in pregnancy when the intravascular volume, which increases in pregnancy, requires modulation. And this usually might be an example would be when valvular disease exists. Let's continue our discussion. So let's continue the discussion further and talk about antihypertensive agents used for the treatment of urgent blood pressure control in patients. And again, these are patients who have a blood pressure of greater than 160 over 110. We've talked about labetalol before as an oral agent that is labetalol is both a beta blocker that allows also for decreasing peripheral vascular resistance. So here you would start with dosages of 10 to 20 milligrams IV and ramp up rapidly every 10 to 20 minutes. And then you would see onset pretty quickly within 1 to 2 minutes. This is usually a very effective medication, and it's usually the medication that most care providers are comfortable with. Again, you want to avoid this agent in the setting of asthma. Hydralazine is another medication that is highly effective in this situation. It's a peripheral vasodilator, and it's used in aliquots of 5 to 10 milligrams, again, administered intravenously every 20 to 40 minutes. Its onset is a little bit slower, but again, if someone has asthma, you would choose hydralazine over labetalol. Hydralazine is unique in that, again, this is one of the oral therapies that can be used, and it's important if someone has severe hypertension and they don't have an IV access, and so you can start treating them orally to achieve treatment goals even faster while starting an IV, which is always important to do in the setting of severe preeclampsia. Nifedipine is a calcium channel blocker that decreases peripheral vascular resistance. It does have the side effect of causing reflex tachycardia, and so the heart rate must be monitored when using this medication. So then, in addition to discussing guidelines for hypertension, now we need to talk about preeclampsia. And again, the American Heart chose to embrace the diagnostic criteria that is set forth by American College of OBGYN and the Society of Maternal Fetal Medicine when describing this entity. So I think it's important to describe preeclampsia and spend a few moments discussing what is preeclampsia. So preeclampsia is a disease where there's an imbalance of vasoactive substances where vasoconstrictors overwhelm vasodilators. It is unique to pregnancy, although it can present in the postpartum period for the first time. So let's talk more about the definitions and the criteria. First and foremost, usually the hallmark is elevated blood pressure. And mild to moderate preeclampsia is defined as a systolic blood pressure of greater than 140 millimeters of mercury or a diastolic of greater than or equal to 90 millimeters of mercury on 2 occasions, separated by at least 4 hours after 20 weeks of gestation in a patient with previously normal blood pressure. If severe blood pressure is noticed, this would be consistent with severe preeclampsia. And again, the criteria would be a systolic blood pressure greater than or equal to 160 millimeters of mercury or a diastolic blood pressure of greater than or equal to 110 millimeters of mercury. And with severe hypertension, you wouldn't wait 4 hours. You would want to confirm this within minutes so you could facilitate timely antihypertensive therapy. And remember, this is a danger zone where there's an increased risk of loss of autoregulation of blood flow leading to the potential of stroke. And that's why it's paramount to treat both outside and in the setting of pregnancy. So not only is preeclampsia involve blood pressure criteria, but there's additional criteria, which we'll now discuss. Proteinuria is one of the components, and this is defined as greater than or equal to 300 milligrams per 24-hour collection, or a protein creatinine ratio of greater than or equal to 0.3. In previous years, a dipstick measuring protein quantitatively was used, but this has fallen somewhat out of favor due to the ability to monitor it from its quality control. In the absence of proteinuria, you can still have preeclampsia with new onset of hypertension with signs of end organ damage. And depending upon the severity, you will diagnose severe preeclampsia, particularly when you have thrombocytopenia. But when the level falls below 100,000 platelet count, this is consistent with severe preeclampsia. Renal insufficiency, when the serum creatinine concentration is greater than 1.1 milligram per deciliter, or a doubling of serum creatinine. Remember that due to the physiologic changes of pregnancy, creatinine is lower in pregnancy. And so we usually find the level to range from 0.4 to 0.6 milligrams per deciliter. So doubling that would indicate severe disease. Additionally, impairment of liver function with elevated liver transaminases to twice normal would signify severe preeclampsia, and the presence of pulmonary edema and the new onset of headache are particularly alarming signs of severe preeclampsia. And the importance of this criteria is to guide management. Usually severe preeclampsia, even remote from term, requires judicious monitoring and consideration for delivery, even when prematurity is a risk. The consistency throughout the societies, the American Heart Association, the American College of OBGYN, and the Society of Maternal Fetal Medicine. It takes a team to build a village and to protect the patient who has sustained an adverse pregnancy outcome to decrease the risk, the lifetime risk of cardiovascular disease. For review, again, I want to just drive these points home. We've talked about the levels of hypertension and what's normal and what's abnormal. The American Heart emphasizes that for prevention and correct management of blood pressure, it's important to stratify and identify each individual's risks so that they can be appropriately guided for strategies of management. In pregnancy, non-hypertensive individuals will have a blood pressure of less than 140 millimeters of mercury and less than 90 millimeters of mercury. Hypertension will be defined as 140 millimeters of mercury or higher, and a diastolic blood pressure of 90 millimeters of mercury or higher, with severe hypertension requiring immediate treatment of 160 millimeters of mercury or higher, or 110 millimeters higher for the diastolic blood pressure. And again, emphasizing that there is a consistency amongst all of the society, creating a common goal for management strategies. We're almost done, but I have a few other aspects that I want to emphasize just so that we can carry these throughout the rest of the webinar for discussion. For pregnant patients with chronic hypertension, that is high blood pressure before pregnancy or diagnosed before 20 weeks of pregnancy, the new guidelines emphasize blood pressure control. We know that decreasing the blood pressure below 140/90 is not going to cause harm to the fetus, leading to growth restriction, but rather it's going to improve both perinatal outcomes for the pregnant patient as well as the fetus. Low-dose aspirin is important. It won't lower blood pressure, but it will prevent the development of superimposed preeclampsia. And this patient population with underlying chronic hypertension is especially vulnerable to superimposed preeclampsia. And aspirin is our best strategy to decrease that risk. I want to emphasize that postpartum care is especially important because this is a time period when not only blood pressure will persist and require careful management and adjustment, an ongoing assessment to develop a lifelong strategy, but hypertension can develop for the first time in the postpartum state. And this is why close care is really important. Postpartum care is so much more than just a visit 6 to 12 weeks after the delivery. The guidelines urge continued blood pressure monitoring and timely treatment during the postpartum period to help prevent complications. And patients with a history of pregnancy-associated high blood pressure are encouraged to have their blood pressure checked and measured annually. They need to be highly educated as to their lifelong risk of increased cardiovascular disease and strategies that must be instituted immediately to begin to combat those risks. And for my final thoughts, I want to emphasize hypertension thresholds across pregnancy and postpartum. Again, the American Heart has chosen to incorporate pregnancy into their guidelines so that they could introduce pregnancy hypertension to the to other healthcare providers and professionals, not just those immediately involved in providing obstetrical care. This is a team effort, and all healthcare professionals need to be educated about hypertension in pregnancy. No longer is it just for the obstetrician. I also would like to reinforce early identification, the importance of accurate diagnosis and timely management. I also need to underscore the importance of implementing lifestyle modifications and follow-up care. It's not just about medication, but lifestyle medications are a little bit harder to institute, and they have to start before, during, and after pregnancy. Again, I want to emphasize the fact that American Heart has aligned their definitions, embracing ACOG and Society of Maternal Fetal Medicine guidance for continuity and clarity throughout the life cycle, throughout the reproductive life cycle, again, to address the increased risk for cardiovascular disease that occurs after a complication or an adverse pregnancy outcome. And finally, we need to support equitable, evidence-based care to improve maternal cardiovascular outcomes. I thank you for your attention, and I enjoyed being with you today.
Thank you so much, Dr. Zella, for that presentation. If you have any other questions for Dr. Zella, please do use the Q&A function on your control panel. We'll be addressing them post-webinar. Next up, we have Dr. Ferranti and Dr. Suppley. Dr. Ferranti is an associate professor at the Emory School of Nursing, and Dr. Suppley is the director at the School of Nursing and Aaron Black Distinguished Professor at the University of North Carolina, Wilmington. The floor is yours.
Thank you, Alizé. If we can move to the next slide. And I just want to thank Dr. Zella for providing such a great start and introduction to managing blood pressure during pregnancy. We're going to move into talking about managing blood pressure and hypertension in the postpartum time period, which is really, really important, particularly for women who've had adverse pregnancy outcomes. We know that they're at significantly greater risk. And in all actuality, we know that the majority of maternal deaths actually happen in the postpartum time period. So the American Heart Association and many other organizations have devoted a lot more time to focusing in the postpartum time period. And so we'll highlight that now. So next slide, please. So really thinking about the postpartum time period as the fourth trimester, so those next 12 weeks after delivery is really key. Typically we bring women back about 6 weeks after delivery, but for women who've had adverse pregnancy outcomes, particularly hypertensive disorders of pregnancy, it's really, really important to get them in for an earlier visit. So as you can see with the citation at the bottom of the slide, back last year, the American Heart Association put out these recommendations for opportunities in the postpartum time period. And so really recommending an earlier visit in those first 3 weeks to monitor blood pressure and to really encourage home blood pressure monitoring, either via telemedicine or through some other mechanism. If patients have not already been connected to a cardio OB team, it's highly recommended that that happens in the postpartum time period as well, or referred to a cardiologist as necessary. Continued postpartum follow-up with the OB team. And if there's overlapping gestational diabetes, a glucose screen should be done early in that time period. And then contraceptive planning for those with hypertension or cardiovascular disease, and really talking through that. Those conversations should really begin during the prenatal period, but reinforced in the postpartum period as well. Discussing the feeding plan and discussing the medications as Dr. Zella recommended during pregnancy and what continues to be safe during lactation. And then recognizing the signs and symptoms of cardiovascular disease. And I think this is really, really key. For those of us that have worked with patients in the postpartum time period, we know that things like swelling and fatigue and exhaustion can be normal signs of just delivery recovery, but they can also be signs of greater and increasing cardiovascular acceleration. So really need to educate our patients about that. And of course, nutrition and education counseling. And then at that typical 6-week postpartum checkup, all the way up to a year, really continuing the follow-up care. So really focusing on Life's Essential 8, which is part of the American Heart Association. Continued close blood pressure monitoring. We, particularly like we said with the home monitoring, people's blood pressure can be very different at home than they are in the office. So making sure we're getting accurate blood pressure measurements. Transition of care to more longitudinal clinicians, whether that be family planning, family medicine, primary care, preventive cardiology as necessary. And, particularly for women with history of adverse pregnancy outcomes, really linking and having that warm handoff between providers. We talked about Life's Essential 8 already, so just really reinforcing that. And any imaging that might need to take place, again, in consultation with cardiology, and then education on the association of the adverse pregnancy outcomes and long-term cardiovascular risk. I feel like we're getting better at this, but we were, for years did not talk to women about their long-term risk after an adverse pregnancy outcome. And then moving into the longer 1 year and beyond, really encouraging annual health assessments, encouraging women to always report that they've had these adverse pregnancy outcomes so that their entire healthcare team is aware of their additional risk. Continued Life's Essential 8, cardiovascular risk assessment, looking at lifetime and 10-year risk, and really, making sure we're doing that for everybody, but particularly women for adverse pregnancy outcomes. Then looking at the foray of all cardiovascular risk, so dyslipidemia, type 2 diabetes. We know women with adverse pregnancy outcomes, particular hypertensive disorders of pregnancy, are at higher risk for all these other risk factors as well. And considering metformin for type 2 diabetes, medications for hypertension, weight management, and then continued contraceptive counseling. So next slide, please. And because so many things play into why women have adverse pregnancy outcomes and hypertension, we really need to look at the full ecological framework and all the factors that play in. So at the individual level, as we just discussed in the last slide, really focusing on Life's Essential 8 and risk management and risk assessment. And then to us as the healthcare team, being aware of the new guidelines and the comprehensive guidelines for really making sure that we're mitigating this risk and taking this really seriously. And then as a healthcare system, setting up systems where we can really monitor women, promote remote blood pressure monitoring, have transitional care clinics, have cardio OB teams and other interdisciplinary teams where we can have comprehensive care, health coaching, group weight loss programs. And then more at the community level, looking at home visitation and community health worker programs. There's numerous evidence-based programs that are out there that are very effective for both women and children. WIC services, SNAP services, all the services that help women live healthfully, the national DPP, group exercise, and weight loss programs. So looking for those opportunities to connect women in the postpartum time period. And next slide. And so just some more reminders. So particularly, when we're managing women with hypertension during pregnancy, we need to continue that in the postpartum time period and keep a really close eye on it. Remind women that they are at elevated risk and to continue that risk assessment throughout the life course. Careful surveillance, educating the patient and their family members on signs and symptoms. As I mentioned, especially in that early postpartum time period, the symptoms that we have immediately post-delivery can mimic signs of worsening heart disease. So we got to keep an eye on that and let patients and family members know about those risks. So really good discharge education is important, and instructions on follow-up care, when to return for a blood pressure check, when to call a provider, when to show up to the emergency room as necessary, and then strongly encourage women to keep up with their own care. What we see so often is, now there's a new baby in the world, and so we're really focused on the pediatric appointments, but kind of let the women's health appointments fall off, and we really need to encourage women that they need to be a healthy mom in order to be a healthy, to have a healthy baby. So, all right, that's it for me. I'm going to turn it over to Dr. Supplee to take over. Thank you so much.
Hey everyone, so I am going to continue. Some of this may be repetitive, but like we say in healthcare and teaching, the more repetitive that you hear, sometimes something hopefully will stick. I'm going to talk about the planning for transitional care. First of all, addressing some potential barriers that we do find, including new mothers may not feel the follow-up is important, or they don't really understand what's going to happen. Childcare issues and transportation issues are usually high on the list. Getting time off from work. Again, many women do not get the luxury of getting time off from work, so they're right back to work. Some sometimes within a few days of delivery. Timing of when this care occurs. So again, you've heard us talk about, getting people in earlier for blood pressure checks if they do have a history or if they have had preeclampsia. But at the same time, the point of it is the knowledge related to the current and future CV or cardiovascular risks are really important to discuss with the patient. The other thing we always have to add are cultural preferences with regards to what's going on during this time period of transition. The next thing is reinforcing life changes and risk factors. During the postpartum period, women have both a physical, psychosocial, and family adjustments to make, but we have to be very careful of education overload. It's amazing sometimes how much education is done right when the patient is leaving the hospital or the midwifery center, and at the same time, they're packing up their bags, they're getting their baby ready, and they can't really be fully listening to the conversation. So it's really important for us to do a better job of when the timing of the education and the readiness to assess the patient. Knowing that they are at risk of developing cardiovascular disease later in life or with the next pregnancy is important. Again, it may seem far away, but the next pregnancy may come up quickly versus just understanding that this is the time to actually change some lifestyle issues. Providing women with a comprehensive discharge information sheet can be another lifesaver in a way. They need to be able to share this with future providers. You can encourage them to take pictures of this sheet versus putting it on their phone. Again, we did one study where many women were actually going to different health centers, ERs, outpatient centers, for follow-up care if they had some type of symptom they wanted to report, and therefore that person or healthcare provider did not have access to their records. So it is great if you can give them something that would really enhance what they have. High blood pressure monitoring and telehealth and texting, it's a very useful tool. Again, we have to teach how to take the blood pressure correctly, when to take it, who to contact if that blood pressure is elevated. And obviously we want to provide numbers and stress the importance of taking more than one blood pressure. We are getting into texting reminder systems that have been working, supporting individual needs for hypertension control. Again, there's many challenges they face when understanding that it's them that has the blood pressure. And sometimes this is a younger population that they're not used to hearing about. Providing information about the postpartum checkup remains underutilization. We do know that many women never return for the checkup. So again, the importance of providing potential warning signs before the person leaves the hospital. We're going to talk about reviewing nutrition and exercise and stress management on the next slide, but I also want to reiterate the importance of considering obtaining maybe lists of cardiologists that will provide care for postpartum patients, that people aren't searching for referral people during the time of discharge, and obviously providing the name and woman the contact information. Follow-up and risk reduction, you've heard before, an annual health exam. When you're discussing lifestyle changes, for example, and you can move to the next slide, please. What you're going to find is that, just don't talk about you should eat a healthy diet, you should lose weight, you should X, Y, and Z. It's not helpful. It's not education. What we really have to provide is realistic guidelines. So again, increasing water intake, smaller portion size of food, altering ways to cook food and how to handle temptation of snacks, for example. I think the other thing is the heart-healthy diet. We have to really focus on diet, exercise, and nutrition, and basically because we make a big assumption that people know what that means. So again, getting more into the nitty-gritty of what a heart-healthy diet can look like. Activity can start with walking. I mean, it's the most basic exercise and it's the most fabulous exercise to start with in the postpartum period. So even again, if people can start with walking, that is great. The other thing is stress management. If you tell a person to decrease their stress, what does that mean? What are they supposed to do with that information? So again, assess the history of depression, anxiety, other mental health conditions that have potential to change with progression of pregnancy and after delivery into the first few years of child rearing. I don't think we do a good enough job with this assessment because again, we could see there is connections between, for example, depression and hypertension. Alcohol and tobacco use decreasing, obviously. Sharing information with friends and family when educating, have people listen in so there's more than one pair of ears listening. And then obviously considering preconceptual counseling, increasing awareness the risk of hypertension or preeclampsia with the next pregnancy can provide early intervention. Next slide. I want to briefly talk about taking a blood pressure correctly. You know what? This is an assumed task that you will see. It happens to everyone. But again, majority of people sometimes are not even taking the blood pressure correctly. It should be while seated, supported arm at the heart level. If the blood pressure is taken while your arm is on your lap or hanging to your side, you actually get an elevated reading. It could be 4 to 6 points higher in systolic numbers. The other thing you will find is that if the blood pressure cuff is not the correct size, if it's too small, for example, you're going to get an elevated reading, too big, a false lower reading. And if it's too loose, you'll actually get a false elevated reading. Other factors that go into blood pressure checks, feeling stressed, having it done in a noisy space. You should be emptying your bladder 30 minutes before you have it taken. Caffeine and exercise can affect it as well. So again, 30 minutes. And measuring the same time each day, especially if you're doing home monitoring with blood pressure cuffs. But what I have to say is, it's incredible how many times you walk into a provider's office, first thing they do is they take your blood pressure. And again, it's really not the best time to take the blood pressure. It should wait for a while before everything kind of calms down. And you also should take 2 blood pressures, waiting a minute in between to see if there is any difference. We all know that pregnant women obviously should not be flat on their back. It's going to elevate their blood pressure. So you do want them wedged. And again, in the postpartum period, obviously, we could go back to taking it with them in the sitting position. Next slide. Getting into the community and society, we want to collaborate with community leaders, offering blood pressure screenings of all adults. Reach out to schools in the neighborhood. We're constantly looking for places that students can practice blood pressures. Share updated information with healthcare personnel and caseworkers. Again, Healthy Beginnings, Family Connects programs. Keep them updated on these current guidelines as well, because they can also be another step in the progression to education and follow-up. You also can showcase cardiovascular health at community events for different populations. And just talking a little bit about education and academia, we want to teach best practice for taking a blood pressure. That's one of the most important things we can do. Integrating the latest guidelines into nursing education at all levels, from pre-licensure to doctoral. Engage in simulation exercises and debriefing. Reinforcing the needs for clinicians to be up to date on current guidelines and evidence-based practice. This is where it starts in nursing school. Have students share guidelines with nursing staff, bring those guidelines when they go to clinical. And last one, during interactions with community members, present the latest information at the reading level and literacy level of the learner. For example, when you start with health fairs. Next slide. And these are just some additional resources for you. The AIMS bundles, they have a hypertension bundle, which is great. And also AHRQ have toolkits to reduce hypertension in pregnancy and obstetrical hemorrhage. And obviously the latest guidelines that have come out and have been published in 2025. Thank you.
Thank you so much, Dr. Stupley and Dr. Ferranti. Now going on to our final session for today's webinar, we have Dr. Crystal Graves, who is a clinical nurse improvement coach serving in the Iowa Prenatal Quality Care Collaborative. Dr. Graves, I'll pass it over to you now.
That's great. Thanks so much. So I am going to share just a little bit about what you can do in your setting, especially my focus is on the rural setting also. Been my background for 23 years, and I live in a very rural community, have to drive out of my county 40 minutes away to the closest hospital and to an OB unit. So I'm going to talk a little bit about what this might look like in ERs and in the rural setting. All right. So first and foremost, if we are working with hospital settings, birth centers, OB units, your ER, your urgent cares, anywhere where a pregnant or postpartum woman might go to, they should all have this correct information. However, when you're working in an ER or an urgent care, you have to think about so many different things. So having a guideline, a clinical workflow that tells you what to do if this pregnant or postpartum woman comes in with these signs and symptoms, with elevated pressures, this clinical guideline is super helpful to have it either integrated into your EMR to build you a order set, or just even a cheat sheet to follow along with. Part of my job is simulation in Iowa, where we travel to ERs and urgent cares, and we leave them with a guideline and we say, post this somewhere, either with your OB pack or somewhere where your providers can see this if this comes in. This is just one example of a great guideline that was put out by ACOG that literally walks you through who's at risk for preeclampsia in pregnancy and postpartum, what are those signs and symptoms, and then what labs should you be getting? And then it literally leads you right into how to treat these patients, what medications, what dosing, how frequent to give them, what kind of follow-up we want to see. Just mentioned by my previous colleagues is there's an AIM bundle on hypertension. Many states have implemented that in an OB setting, maybe haven't gone to the ER settings, but there is ER options in there on how to utilize it. One of them, a question I just saw that came into the Q&A was, how soon should these women be following up if they have high blood pressure? And in that postpartum setting, we're actually saying if you had severe range pressures, you should be seen within 3 days of discharge. And if you had any elevated pressures, you should be seen within a week of discharge. And it was mentioned previously, many of these women are so hyper-focused on that newborn, they kind of forget about themselves, or they think that appointment's not super important, and it really is. And then they come into an emergency room and urgent care with that severe headache, not realizing that is postpartum preeclampsia, and can sometimes be missed if we don't get those proper labs. So having a great guideline, clinical flow like this to follow can be very helpful to remind your staff working in ERs, urgent cares, and clinics what those signs and symptoms are, what labs to get, and how to properly treat it. So for those pregnant women that are coming into those rural settings, having that algorithm that you can maybe even build into an order set is super helpful. I love that the American Heart Association ACC guidelines now include pregnancy and postpartum threshold, because we now can just say, this is by ACOG, it's by AHA, everyone is saying, here's my parameters. What our simulation team sometimes does is I'll walk into an ER, and I'm advanced maternal age, but I'm still in that childbearing age years. And I say, gosh, I have this horrible headache and I've got this kind of heartburn, and I get worked up for chest pain, MI. And sometimes I'm never asked, could you be pregnant? Have you had a baby in the last 6 weeks or a year? And then that really is my opportunity then to say, you need to ask those questions, because in this simulation, I would have said, I just had a baby 6 days ago, and how would that change your care for me? So now that they have these guidelines that say, look at these women and look at what those blood pressures are, super important. We also want to asking anyone with a uterus if they could be pregnant, if they are pregnant, they've had a baby in the last year. What we want to go away from is asking that last menstrual period. We have birth controls where women never get a period. We have some women that throughout their whole pregnancy still have spotting and think it's their period. We also have women that will get a period back within a few weeks of having a baby, but they're still at that high risk for postpartum preeclampsia. And if we just are asking last menstrual period, we might put some blinders on and not realize she's still at high risk. So we would like those questions to change to, are you pregnant? Could you be pregnant? Have you had a baby in the last year? And then really looking how we physically assess these women. There's some things that us OB nurses and providers do that a lot of ER nurses, urgent care, EMS, just isn't in your wheelhouse of normal things that you do. One of them being deep tendon reflex can really tell an OB provider, an OB nurse, if we're going to consult with them, how severe that patient is. If she's got hyperactive deep tendon reflexes, and if she's got 3 or more beats of clonus, that's really going to tell that OB provider, I've got a patient whose central nervous system is hyperstimulated and she needs to get care pretty quickly. And that's really going to tailor what they're telling you to do for that patient. And if we can add a couple of assessments before we make those phone calls, that's great. Knowing that that headache, 70% of preeclamptic women who end up having an eclamptic seizure had a headache prior to. So it's huge. We really stress to our EMS and ERs, if she comes in with a headache, we've got to know if she's recently had a baby or if she is pregnant, because that's a huge indication. In fact, you can now be considered severe features with just a headache, and you could have normal labs, but that headache is enough that it has made ACOG change their tune on that can actually give you now that diagnosis of severe features. Visual disturbances, there's a lot of other things, but know what those are if you're working in those settings. Also going to highly encourage you do simulation in your practice. We find this to be very beneficial on how to properly assess these women, how to properly treat them, what kind of questions do we ask. Preeclampsia is one of those low frequent but very high risk patients that we want to make sure that we practice how we assess and how we treat. In most OB settings, we're saying, if you get that severe range pressure, which remember is that 160 or 110, you repeat that blood pressure in at least the next 15 minutes. And we want her treated with an antihypertensive in at least 60, but preferably 30 minutes. So really knowing how to properly assess and how to get some timely treatment is really important for these women to get them out of that high risk stage. All right, we're moving on into questions then. Does anyone have anything that we need to answer in our Q&A? Do you know that, Eliza?
Hi, Crystal. Thank you so much. We did have quite a few questions that came to our Q&A. Some of them we are going to save so Dr. Zalop could answer them post-webinar, and we will be sending them in an FAQ document. I would love to see if our speakers have any specific questions that they'd like to answer.
I think I kind of answered a couple on blood pressure scheduling. For the postpartum period in particular, like I said, if they have severe range pressures in the hospital, ACOG and AIM actually say within 3 days to get a follow-up. 3 to 7, we're really kind of pushing for that shorter range of more the 3-day, especially if we're following the AIM bundles. So that's one that I can answer there if anyone else has anything to add on that.
We also saw a question come in from Kristen around, many women miss their postpartum appointments, which can impact recovery and long-term health. What ideas do you have for improving attendance? Dr. Franci, I did see that you answered that, but I just want to see if you have anything else to add or if any of our other speakers would like to add to that, because I think that's a really important question.
It's a tough question, and I know it's a frequent challenge. I don't have anything further to add than my ideas that I put in the text, but Crystal and Trish, if you guys have additional ideas, I'd love to hear it too.
Yeah, I think one thing is that each population, each clinic, each office follow-up, to really get a better idea of what their own population have as far as barriers. The barriers can really be different depending on the location, for example, the follow-up. So I think it's kind of really asking people within that vicinity of what some of the barriers are to address them. Some places have gotten to offering incentives to actually go for their postpartum visit. Whether they work or not is probably dependent on, again, who's actually taking up the incentive. So, but I think there are things to really get to know the population better and then try to streamline what some of the services you can provide, such as childcare, such as transportation and tokens and things like that.
I love that idea. And I will say that a few of the hospitals that I work with in my state actually do have what are called mommy and me visits, where they'll return either 3 to 5 days and it's a combined visit. And you do find that a lot of moms will come and get assessed then because their baby is getting assessed. And some of our hospitals actually will hand out a package of diapers or a coupon for diapers if they attend those mommy and me visits. So those are something that we can consider, especially like you said, Patricia, if we find that that is one of the major barriers is financial, offering them a token for transportation or giving them a package of diapers, that sort of thing.
Thank you. And I saw a question come in. Dr. Graves, I think this would be a great question for you. Someone mentioned that, they work in a rural health critical access hospital. What other ideas or mentions do you have for those caregivers in rural health ED settings?
Oh, I have so many things. I would say, depending on the state you work with, I would reach out to your perinatal collaborative. Many of them have the AIM bundle that is specifically designated for emergency rooms that can give you some guidelines that are recommended. They'll even give you pre-built simulations to practice within your ER to identify where your weaknesses are and so forth. My contacts on here, I'm happy to share with you what we do in our state. But I really say like these, high risk but low frequency items are great to practice. Like I said, those skills, how to do deep tendon reflexes, what even is clonus? Because that tells us a lot in OB, but not something that's done frequently outside of the OB setting. I would say, honestly, I would reach out to either your OB department that's near you. If you don't have OB in your hospital, whoever you would transport to, oftentimes they will come and do education with you, knowing you're going to transport those patients to you also. So I would see what your resources are of who can just share what they have for checklists and cheat sheets and then those algorithms and offer some education.
Amazing. Thank you so much for answering that question. I think one more question that we could answer, given that high blood pressure is largely diet related, do any of you ever send referrals to dietitians that support women's health, or maybe have some insights that you could speak to that?
Oh,
Dr.
Patricia,
Tiffany,
you're muted.
yeah.
So sorry. It can be a tricky question based on the fact that it might be an added cost to be sent to a nutritionist, unfortunately. But the other thing is that we can clearly educate more of our staff and more of the outpatient, for example, caseworkers and people who are actually seeing new moms in the homes, for example, to teach them about better diet and better nutrition. And sometimes it's really informational, but we have to watch for cultural aspects. We also have to watch for literacy levels, because sometimes what we hand out is not the right literacy level. So that's important as well. But I can't emphasize more the cultural aspects, because if you're not looking culturally at the foods people eat and trying to restructure from there, they may not pay attention to what you're saying. So I would definitely say your handouts and have people get more informed that are actually counseling women.
Great. Thank you so much, Dr. Shepley, for answering that. And I think that kind of takes us to the end of today's webinar. I want to thank each one of our presenters today, Dr. Shepley, Dr. Graves, and Dr. Franci, and Dr. Zella, for your amazing presentations and informing us around these new high blood pressure guidance and as it relates to pregnancy and postpartum. Thank you so much for attending today's webinar. You will receive a post-event survey with some questions that will help us as we continue to develop future educational opportunities, and would greatly appreciate you to take the time to complete. This event was presented as part of our Advancing Maternal Health Through Quality Improvement and Professional Education initiative, with funding support from Merck for Mothers, Merck's global maternal health effort to create a world where no woman has to die while giving birth. Thank you so much, and hope everyone has a wonderful day.